Good morning, everyone. So first, Jack and Jason and Dan, thank you so much for inviting me and for the very warm welcome and the beautiful breakfast. So I'm a geographer, and I started a career as a medical geographer and got into GIS and remote sensing and was doing some environmental modeling and specifically environmental exposure modeling. And then through that, I ended up in health and started working at the National Cancer Institute. So I'm going to be talking a little bit about the spatial context of cancer because that's a recurring theme in cancer control where GI science has much to offer. So, okay, again. Hold on. All right. So our division is a division of cancer control and population sciences, and it has an important mission, and that is to reduce cancer burden and to improve the lives of cancer survivors. And to that end, we both conduct and support research in several cross-cutting areas. The division recognizes the importance of incorporating GI science into cancer control, and we have both supported and organized several workshops as well as conferences where spatial context always reemerged as important, and we realized the need to continuously redefine that context in light of the developments in science, technology, and greater availability of data. The division also recognizes the importance of addressing spatial context at all stages of cancer control continuum. And that's a very useful concept to us because it helps us understand gaps in science. And these are the stages from the etiology, where the cancer happens, all the way to survivorship, and for some unfortunate individuals, end of life. And traditionally, I think that spatial context has been researched more in the first three stages of the cancer control continuum, and less so when it comes to diagnosis, treatment, and survivorship, because for the most part, this is approached with medical doctors, epidemiologists, who are interested in understanding what proportion of people have effective treatment, how many of them survive for a long period of time, for how long, and less so asking a question where that treatment occurs, where is that diagnosis established, and where is the quality of life for cancer survivors better. I think we are more increasingly supporting this part of continuum as we have in the past. So these are the priority areas in cancer control where GI science can help us understand the fundamental question of what constitutes the meaningful geographic context. And across these priority areas, we have different kinds of contexts, right, that span across all scales, all geographic scales. And when it comes to cancer surveillance, we are collecting data across the country from individual cancer patients. They're recorded in central cancer registries, and we are mandated to report those cancer statistics every year. And we are typically doing that by county and by state, within the predefined political boundaries, that is. So this is helping us understand the cancer burden, and we express these in the measures of cancer incidence, mortality, prevalence, survival, and related. And it helps us understand where we are when it comes to fighting, or rather reducing, cancer burden. In this whole picture, mapping plays a fundamental role, certainly, and these are the principal resources too that we have at the National Cancer Institute. The Geographic Information Systems and Science for Cancer Control is primarily focused on educating people why spatial context matters, and also visualizing different aspects of geographically based cancer-related information. Whereas state cancer profiles, this is a result of long-standing collaboration between NCI and CDC, where we combine data from cancer patients across the country and building what is called a profile of cancer through combining series of maps, graphs, charts, tables, to better understand how our state fares against other states or counties in the US when it comes to understanding cancer. Now, we are facing some rudimentary challenges here, and there's numbers when it comes to mapping, and this is an example of people trying to compare maps and rates and taking a state as an island and then comparing them based on the distribution of rates within the respective states, in which case in the red on the New Mexico state, as you can see, that rate is on an average lower than the US rate for mortality of all malignant cancers, whereas Kentucky has on an average, again in red, higher mortality rates than the average US. And so if as you know, the way to look at this is to look in the totality of US and the totality of distribution in the US. Because if you look at it this way, this is quintiles, this is the 20% of each state with elevated rates, and people conclude that both states require equal attention to, focused cancer control interventions. Whereas if you look at it in the totality of US, Kentucky has the highest on an average incidence rates of, or rather mortality rates of all malignant cancer in the entire US, whereas New Mexico has the lowest. So there is an issue of classification of rates, and we are typically, and this is traditionally done in all paper atlases, where we are classifying based on quintiles. And we are not too happy about it because it doesn't account for the outliers. We have been looking at David Wong's research about the classification whereby the user can customize a number of classes and eliminate those classes that have a lower probability of being different from the neighboring class. And he has developed, we just saw it recently, we talked to him about it, but his interface is so sophisticated that our user who wants to click on the map and see the map, going with the slider, it's difficult. So we will still work and consider, if the ways to embed that behind the scenes so that it sort of works on the fly, and that way we can present more realistic geographic patterns of cancer. And this is where we report cancer rates, and it has long been recognized that county is not an ideal unit for reporting cancer rates. For one, because of the wide variation in population across the counties, so that the rates, the comparison of rates is difficult. For many counties, the rates are suppressed because there's not sufficient number or counts to generate stable rates. And of course, there is a risk of identifying individuals. So it brings about the confidentiality issue. So how do we deal with this? We aggregate, and NCI developed these health service areas where they have nested counties within the boundaries. And they're developed because, as you can see here, these are the groups of counties where the majority of population uses the same hospitals. We are aware of dangers, but then again, the user wants to click on a map, and what do they do if 80% of the county is suppressed? So they would like to see something of this sort. To get away from this, if you thought that was complicated, so you can see this, whereby Kentucky has developed, and Kentucky, I'm not picking on them, it's like every state pretty much now develops regions. There are health regions for different things, and they report as the mental health. There's all kinds of examples. Now for us, why is that complicated is because of the fact that if we were to report rates and randomly pick one of these classification, and then you want to compare across other states, then you face this situation of just, we want to streamline that process, opposite of streamline, opposite of any kind of logic there. So, if you cannot win, then you join. So we started working on leveraging some knowledge, Jerry Rushton, Sarah McLafferty, and others, and trying to figure out, and Fawei Wang, not to exclude Fawei, very importantly so, to try and actually achieve something that it's difficult to achieve if you aggregate to other political areas, because when we aggregate at health service areas, the population variation still remains. So over here we are trying to achieve some areas that have equal, or rather similar population size, to achieve stable rates, enough counts to report rates without compromising confidentiality. But then again, and there is several other criteria, such as respect existing health regions, joining census tracts, making them more compact, cross-county boundaries, because we will chop some of the counties or portion of smaller counties, and so on. So we use GIS to do that, and then encounter the differencing issue, where if you take a chunk of a larger county and you want to join into a bigger county to achieve the population of 50,000, you may end up, this is a hypothetical example of case counts, whereby differencing you can estimate the purple area, where you can end up with 3 cases and then be able to identify them. We overcome this problem by, there is a strategy by doing something 2-step process, so that wasn't as much of an issue. But then the program delivers slightly different solutions to, and then they can be thousands really, but slightly different solutions of areas that you can combine together. What we do at the end, because the motivation is to make these areas meaningful to stakeholders, those are the cancer control planners. But then do this, the idea is to do this for the entire US to prevent people from doing their own custom zoning for cancer reporting. So this is where we are. We created this, asked the stakeholders from Louisiana Tumor Registries and several others. We worked with California, Greater California as well, and then develop a website for cancer reporting, so that as per their advice or expert knowledge of what are the meaningful neighborhoods to report those statistics, develop these areas. We still face a big statistical challenge now, looking at the variation in race across the different scales. Some of them are masked at the smaller scales because of the low numbers that create bias, and so that's ahead. I'm not going to spend too much time, food for thought. What we are doing is basically out of necessity, I think. But again, I'm here to learn more about it. So there's this other approach where we have a cohorts of patients, and we are looking at their contextual environment, and the scale is much smaller. We go from the and the positional accuracy is very important. So that is in all of the priority areas, right? While I shouldn't, I would like to also share that when we are doing collection within the predefined boundaries, it's not just for purpose of collecting data. We do ecological analysis across all of these areas, right? Because that's traditionally been done. With the surge of data, we are moving more towards this individual context. And in that vein, we are trying to use the more available residential history data, because we're trying to capture these multiple interactions of individuals within social as well as environment that may have lasting health impact, that prior to this we have not been able to capture. And this is particularly true for exposure assessment, so to minimize misclassifications of exposure. There is another important thing in cancer surveillance. We do not have address of patients prior to diagnosis. So we don't know what happened. I mean, we can only guess and have these pretty uncertain models. And there is, in terms of cancer surveillance, it's important if a person is diagnosed in one cancer registry in one state, and then that person moves to another state and develops, unfortunately, another cancer, then another cancer registry may pick up that person and register there. So we need to be able to recognize that that's one and the same person. Otherwise, our cancer burden is twice as big or 3 times as big. So that's beneficial to us. So far, we've been able to link to our databases about 3 million addresses for 3 million patients. We didn't include the population below the age of 21 because the addresses are sparse. And this is what we are dealing with at this present moment, right? There's a lot of that information that is duplicate, there is the quality and lag in quality, and we need to understand how often to link the data. That's expensive. So we are working on understanding how often, what proportion of people are moving from one state to another, and what is the relevant unit. For our researchers, it's important to know within their census tract. For maybe our leaders, it's important to know from state to state because of the fact that they want to catch that moving patient. So these are some, again, questions for GI science community to help us with. And in that vein, we developed this funding opportunity announcement, part of which R21 is dedicated to methodological solution to understanding residential histories and the pretty much linkage of those. And then algorithms to deal with the duplicate addresses, to cleaning the data and to linking the data. Whereas the other one is geared towards the substantive research. Once you have these methodologies developed, then address questions that are relevant to cancer epidemiology and outcomes. So that's that one. And then there is certainly a wish to augment our data with the methods, models, methods for mining big data, and we, would like to invite the GI science community to help us understand how that can be, these data can be integrated and then help us define the context with greater precision that we have done so far. There is this wishful thinking of how we recreate the world real-time community, so we understand where is our cancer patient, because we have no idea where they are. It's just that blob on the map, and so that reality would be fantastic, and reading more and more about that. So Harry Miller, I believe, has been working on that. So anyway, again, recurring theme is data linkage and confidentiality, and this is a big deal for us, and we would love to see how that pans out. And I think we have a speaker on confidentiality, don't we know? I can't wait to hear that talk. So the latest funding opportunity announcement came out last week. It's a different mechanism. It's called NOCI, whereby grantees can apply through different mechanisms, and it's all dedicated to integrating geospatial science into cancer control. And I'm happy to share slides will be shared so that these links can be offered to a greater research community. And this is a sort of a conclusion. The goal is to understand cancer risk and outcomes, and more importantly, to understand what is the meaningful context, and to redefine on, just because to add precision of not only understanding cancer risk and outcomes, but just to inform cancer control efforts to reduce cancer burden. Thank you. Thank you.